Bismillah ar-Rahman ar-Rahim. It is my pleasure and honor to be with this very prestigious gathering from the nephrologists in Egypt and the Arab world. Today I'm going to speak about updated and practical approach to the management of secondary hyperparathyroidism. I like this topic, and we enjoyed so much 3 consequent webinars conducted by Professor Ahmed Hussein from United States. Professor Ahmed is a real expert in the CKD-MBD, and you can track these three videos to know new paradigm in thinking how to manage the patient with CKD-MBD or renal dystrophy. And this is also another video presented by Dr. Amr about the dynamics of osteoblast and osteoclast and how the bone remodeling occur. This is another video, one of the very nice videos by the great Professor Rashad Barsoum under this exciting title, Bone, Kidney, Talk and Noise. I recommend all of you to see, just to know how kidney and bone interact together. This is one of my favorite talks about CKD-MBD. This is why every year or every 6 months I update CKD-MBD. Today, I'm not going to discuss CKD-MBD. I am focusing on hyperparathyroidism. To start with, a physiology and the pathophysiology of parathormone. This is the parathormone from 1 to 84 amino acids. We have N-terminal and the C-terminal. Both of them have opposite effects, but at the end of the day, intact PTH is very valuable hormone that helps the body for the homeostasis of calcium, phosphorus, and bone remodeling. Why? Because parathormone works on kidney, intestine, and bone. On kidney, it activates vitamin D and increase phosphate secretion or reduces phosphate reabsorption. On the gut, it stimulates calcium and phosphate absorption. On the bone, it increases FGF23, calcium efflux from the bone and the bone remodeling. So this is, we need parathormone, and it is secreted in pulsatile nature. And this is why it is difficult, if we have a dynamic bone disease, we cannot give parathormone as replacement as we do with hypothyroidism. So it is not for replacement. This is a problem. Although it is very valuable hormone in the body. How it works? Bone, kidney, parathyroid, endocrine axis. It is clear from this figure that kidney, through activation of vitamin D binds to its receptor, vitamin D receptor on the bone on osteocyte. With the presence of nuclear factor, this will stimulate the release of fibroblast growth factor 23. So this is the first step. FGF23 that is released from the bone. So here we have kidney, bone. Kidney activates vitamin D, and the bone releases FGF23. FGF23 binds to its receptor within the parathyroid gland and within the kidney, with the presence of co-receptor Klotho to inhibit parathormone release and inhibit vitamin D. So FGF23, although it is activated by vitamin D, but it inhibits parathormone and vitamin D. So if we have normal PTH, normal FGF23, normal vitamin D, everything will be normal. What happened in chronic kidney disease? In chronic kidney disease, we have disturbance of all these homeostatic mechanisms, starting with reduction of active vitamin D through inhibition or reduction of 1-alpha hydroxylase. So a reduction of active vitamin D, this means that there is inhibition of vitamin D receptor. In the same moment, there is deterioration of kidney function with retention, some degree of retention of phosphorus that stimulate parathormone. So parathyroid gland starts the journey of hyperparathyroidism. So this is the environment. So environment of the kidney, as you see in this very nice figure, this is a new textbook about parathyroid gland in chronic renal kidney disease in almost 200 pages. If you look at this figure shown within this book, these are the stages, normal kidney and different stages of chronic kidney disease. If we are enjoying healthy kidney, everything is normal. All hormones are normal, FGF23, beta-H, Klotho, and the vitamin D is normal, or activation of vitamin D is perfect. And both calcium and phosphorus are normal. Everything is normal. Parathyroid gland is normal. What happens if chronic kidney disease start? With starting chronic kidney disease, as you see here, so in normal situation, there is normal vitamin D receptor, normal calcium sensing receptor within the parathyroid gland. So parathyroid gland is healthy and normal. With development of chronic kidney disease, there is a reduction of vitamin D receptor and the calcium sensing receptor. This will start the process of diffuse hyperplasia of parathyroid gland. And concomitant with this, increasing FGF23 and the parathormone. Why they are increased? Try to reduce phosphorus and control phosphorus. So with deterioration of kidney function, Klotho and vitamin D are reduced. FGF23 and the parathormone are increased, trying to control phosphorus within normal. Ultimately, at the end of the spectrum of chronic kidney disease, phosphorus or phosphate start to rise. So at the end of the spectrum, we have increased FGF23 with resistant to its action. So phosphate increase, parathormone is high. Concomitantly, the gland start to grow, then to be nodular. With this increasing parathyroid size and activity, you'll find the clinical manifestations. So this is the evolution of the spectrum and the changes of hormones and mineral. We have guidelines, the KDIGO guidelines, that was updated in 2017, and the Chinese guidelines. One of the very important messages when we want to evaluate parathyroid gland, we should look at both phosphorus, serum calcium, alkaline phosphatase, and intact beta-H, and at certain point of time, vitamin D. We need this frequency of assessing both serum phosphorus, calcium, and alkaline phosphatase and the intact beta-H. This is just on the stable patient. But if there is derangement, we can increase the frequency of testing. So if we find hyperphosphatemia, hypercalcemia, or hypocalcemia, very high level of beta-H, we may need even to monitor calcium and phosphorus even weekly in dialysis, and the beta-H instead of 3 months to be tested monthly. So according to the profile, we increase the frequency of testing. One of the very nice clarification that was clarified by Professor Ahmed Halawa in the last meeting is beta-H assay. We should know how to assess beta-H. First generations, which is polyclonal, is obsolete now. We here in Egypt, we have second generation. In the United States, there is third generation, and we should know the limitation. Second generation measured both C-terminal and N-terminal. This is why we should be cautious, because beta-H, if you find beta-H by second generation, for example, 300, may be due to excessive C terminal. So if we react on this value of BTH by aggressive drugs targeting parathormone, this may increase the risk of a dynamic bone disease. This is why KDIGO guidelines put target of parathormone to be between 2 to 9 in hemodialysis patient, the normal values. Why? Because to avoid the dynamic bone disease. So it is better to look at the serial and the trend of BTH rather than absolute figure. Third generation, it lead to direct measurement of biological active BTH, but as I said, it is more expensive, not widely available, and the guidelines currently available are adopted according to second generation. Let us go to secondary hyperparathyroidism. What is the incidence? You will be astonished when to know hyperparathyroidism is present in about 40% in patients with stage 3 CKD. GFR between 60 to 30, this is 40%. And GFR between 30 to 15 in stage 4 CKD, hyperparathyroidism secondary to CKD is almostly available, present in 80 or more than 80% of patients. This is one of the points. Is hyperparathyroidism or bone profile in chronic kidney disease is the same in each country? The answer is not. Why? This is the data came from many places in the world, from Europe, Asia, Middle East, and North America. And this is, here Professor Saeed Al-Ghamdi is one of the authors of this very nice data. And this is the merit of the presence of data registry to share in DOPS. And this is, as you see here, this is the European countries. This is the Asia and the Middle East, and this is Saudi, and North America, Canada, and United States. If you look just very rough, you will find different values for phosphorus, BTH, and calcium. This means that there is difference from country to country. And I think using color tells us more better. For example, if you look at the BTH, green means above 600. So green here is bad. If you look here for Saudi, you'll find a large number of patients have BTH above 600. So this is the other values, and you can look and compare country by country. For example, Japan, you'll find the patients, there is no green color. This means that in Japan, they are controlling the parathormone very well. This is the phosphorus, and this is the calcium. You can find difference here. Phosphorus above 7. Here in Saudi, 12% in comparison to China, 27% above 7. So phosphorus is not controlled well in China, for example. So by looking at the figures and comparing international values, we can know where we are. This is the intact BTH above 600, variable from country to country, and the phosphorus above 6. So the key message from this article is there is variability of calcium, phosphorus, and BTH from country to country. Why? This may reflect the difference in practice, difference in laboratory, difference in management. And I'm going to end with 2 slides from this article, difference in management of each country. What are the clinical manifestations of secondary hyperparathyroidism? Secondary hyperparathyroidism is not restricted to increase the parathormone. It is a multi-systemic disease. It affects badly the heart. As you see, increased blood pressure, myocardial hypertrophy, cardiac fibrosis are consequences of secondary hyperparathyroidism. Brain, increasing cytosolic calcium, cognitive impairment of the cognitive function is very valuable for us as a human being. For diabetes, impairment of insulin secretion and disturbance of the adipose tissues, all these are associated with secondary hyperparathyroidism. In the bone, high bone turnover in intracortical porosity, skeletal resistance, hemobiotic dysfunction, and anemia resistance. All these are associated with secondary hyperparathyroidism. Muscle weakness, sarcopenia, and uremic myopathies, all these are association with secondary hyperparathyroidism. Even increasing CKD progression, there are some data about this point. Tubular injury, so BTH, parathormone, if it is normal in normal person, it is normal, but in renal failure, if it increases, this is one of the uremic toxins. This is a very nice cohort study, shows that BTH, if it is escalated, if it is very high, increasing progressively, this may predict some symptoms like tiredness and skin itch. I mentioned that BTH is increased and FGF23 is increased. What is the problem of this milieu of increasing these hormones? FGF23 is not good by standards, bad. It is enemy. It tries to normalize phosphorus, but at the end of the day, there is a resistance and it increases and it becomes predictor of morbidity and mortality. This study shows blue color means left ventricular mass index, and the red color reflects the ejection fraction of the left ventricle. As you see, the higher the FGF23, the lower the ejection fraction, and the higher the left ventricular mass index, the hypertrophy of the heart. So very high values of FGF23 is not only associated with hypertrophy of the heart and reduction of systolic function, but as well associated with mortality, because survival, if FGF23 is very high, survival is significantly lowered. How to treat secondary hyperparathyroidism? We have two big lines of management: medical treatment and surgical treatment. The new paradigm of thinking is 3Ds. 3Ds means diet, dialysis, drugs. This is the medical treatment. And this is the summary of the target. When we treat hyperparathyroidism, we treat both calcium, phosphorus, and BTH. We don't like to have hypercalcemia. This is why before starting any treatment that may cause hypercalcemia, we should check serum calcium before vitamin D. Phosphorus to be reduced, but actually we don't know the best value of serum phosphorus. The best is try to reach the normal, even if it is high normal range. The BTH in dialysis patient to be between 2 to 9-fold. If the patient is not on dialysis, 2-fold is fine. The manipulation of parathormone is through all these parameters. The first paradigm, the first approach is how to control phosphorus, because phosphorus is a stimulus for hyperparathyroidism. Phosphorus is a uremic toxin, is associated with derangement of all body system. Hyperphosphatemia is associated with disturbance of all body system: skin, cardiovascular, heart, vascular calcification, and even mortality. One of the basic information: what is the difference between phosphorus and phosphate? Usually we use them interchangeably, but just to know that phosphorus is an essential mineral. Because it is highly reactive in nature, phosphorus bound to oxygen to form a phosphate. So phosphate is phosphorus bound to oxygen. By the way, if we say that we need, the normal person need 1 gram phosphorus as requirement daily, if we translate it into phosphate, we need 3 grams. So this is how to convert phosphorus to phosphate. But usually we use them interchangeably. How to control serum phosphorus? We have diet. So if we look at the diet contains phosphorus. So we absorb phosphorus from the diet. The absorption is dependent upon the nature of the diet. Is it plant or animal? Animal has organic phosphorus. So plant, like grains, legumes, nuts, the bioavailability absorption of phosphorus is just 30 to 50%. The question why? Because in plant, phosphorus is bound to phytate, and we don't have, as mammals, we don't have enzyme to catabolize phytate. So the absorption is limited from plant source. This is why in chronic kidney disease, it's better to educate the patient, to advocate plant and vegetables, especially in early stages of CKD. In animal, we need animal proteins, either meat, cheese, fish, because if we avoid animal protein of high biological values, this will be associated with malnutrition and sarcopenia. Absorption of phosphorus from animal sources is ranged from 60 to 90% according to the type of protein. And the dietitian know well if this protein include high phosphorus or not. And according to phosphorus, if phosphorus exceeds 12 milligram per gram protein, this means a high phosphorus containing animal proteins. So we need a balance between animal and plant protein. We don't like malnutrition. But what we should advocate and advise is against all inorganic sources of phosphorus. Why? Because absorption of inorganic phosphorus ranges from 90 to 100%. Inorganic phosphorus is present in soda, so we advise against soda, either regular or diet, prepared foods and canned foods, because they contain inorganic phosphorus with high capability of absorption with no nutritional value. So this is how we manipulate the diet. And even for meat, we boil meat with pressurized kit. Meat is cut in small pieces and to get rid of soup. So soup includes a large amount of phosphorus. So by this way, we keep sufficient protein without excess phosphorus. One of very interesting issue is hidden phosphorus. Where is the source of hidden phosphorus? Food additives, including pH regulators, stabilizers, flavor, color enhancers, may contribute up to 1/3 of dietary phosphorus. Be careful about these points because all these are bad. Supermarket in the United States increased these food additives through these 15 years by 50%. Another point is poor labeling of phosphorus content for the diet and for the drugs. And this is an interesting, if we have the label that clarifies phosphorus, it's better to control phosphorus well. Phosphorus in medication, this is a very interesting. I remember a study done in the United States. They reviewed all medications used by dialysis patients, and they found 200 drugs in the dialysis unit, and they reviewed the pamphlet of the drug. They found nothing about phosphorus in the majority of the drugs. The question is, do these drugs have no phosphorus? So they tested them, and there were strange results. Today, I'm just an example of the hidden phosphorus in drugs. For example, this drug, paroxetine, per tablet, 40 milligram tablet includes 111 milligram phosphate. Amlodipine, which is antihypertensive drug, 10 milligram tablet amlodipine contains 120 milligram phosphate, a big amount that needs a heroic dose of phosphate binders. Lisinopril, antihypertensive, per 10 milligram tablet, 32 milligram phosphorus. Even antidiabetic drug, sitagliptin, per 100 milligram tablet, there is 110 milligram phosphate. So be aware and to review medications, and we shouldn't be astonished of phosphorus is not controlled while we are using phosphate binders and others. And to encourage labeling of the food and the drugs as policy. So phosphorus increases in dialysis patients and in CKD because of disturbance in the kidney. Kidney is the main organ for excretion of phosphorus, and the gut So how to handle the gut is dietary and absorption, and I'm going to explain all these points, and bone remodeling. What about dialysis? Is dialysis an efficient modality to get rid of phosphorus? The answer is yes and no. If we take per day 1,000 milligram phosphorus, so per 7 days per week, it is 7 gram. If we say that the absorption is 70%, this means that we absorb 5 gram per day, per week. If we look at the dialysis, if we practice conventional hemodialysis thrice weekly for 4 hours per session, this is the amount of phosphorus that is removed by this modality of dialysis, about 2 gram. So if we have 5 gram per week, this means that we have positive balance 3 gram to be removed by other modalities. If dialysis is extended, the removal of phosphorus increased according to the modality. Extended hemodialysis, 5 hours per session instead of 4 hours, increase the removal. Nocturnal daily hemodialysis increase. This is the most important. One of interesting point, if you find a patient in peritoneal dialysis program with severe hyperphosphatemia, this may be an indication to shift to hemodialysis, because peritoneal dialysis is not efficient modality to get rid of phosphorus. This is why dialysis, even for dialysis patients, dialysis is not enough, is not sufficient for controlling phosphorus. This is why all of us prescribe phosphate binders. What are the type of phosphate binders? What are the advantages and disadvantages of each type of them? All of us know calcium-based phosphate binders, either acetate, carbonate, or citrate. The pros: increase calcium if we have hypocalcemia, lower cost, and moderate bill burden. The problems are hypercalcemia and cardiovascular calcification of positive calcium balance. Non-calcium-based phosphate binders, aluminum is usually restricted, and we usually don't give aluminum to patients on dialysis, and if it is used, it should be used for the maximum 2 weeks because of the risk of aluminum intoxication in dialysis patients. Non-calcium, like sevelamer, we have two members of sevelamer, either carbonate or hydroxide, hydrochloride. I don't like sevelamer hydrochloride, although it is available in our country, but sevelamer carbonate is better. So the pros, advantages of sevelamer: no systemic absorption, less vascular calcification, potentially decreases LDL, improving in metabolic acidosis if we use sevelamer carbonate. Adverse effects: gastrointestinal tract, high bill burden, high cost, bind fat-soluble vitamin. So this is an important point that I'm going to mention later in this presentation. And the metabolic acidosis if we use sevelamer hydrochloride. This is why I don't like it. Iron. From the publication, although we don't have the iron-based phosphate binder in Egypt, but the publications nowadays are very hot about the iron-containing phosphate binder, and I'm going to present some of them. So iron-based, we have saccharoferric oxyhydroxide. It is the problem, it is of high cost, it's costly, but the advantages: low bill burden, minimal systemic absorption, no iron overload, greater efficacy, increased gastrointestinal motility. So if the patient is constipated, like BD patients, this may be an advantage. Ferric citrate, it is non-inferior to sevelamer. This is advantage, well tolerated, beneficial to target iron deficiency plus phosphate binding 2-in-1, but systemic absorption with potential for iron overload. Lanthanum carbonate, it is twice as potent as calcium and sevelamer. The problem is the cost, systemic absorption, and tissue deposition, toxicity, gastrointestinal intolerance, nausea, difficult to chew. Okay, what are the doses? I'm not going to read the doses, but these are the doses for calcium carbonates from 3 to 6 tablets. Acetate, this is the number of capsules. So a big problem to have this pill burden for the calcium-based. Okay, for the cost, the highest cost is for lanthanum and saccharoferric oxyhydroxide. This is $12 and this is $11 cost per dose. So this is the highest cost, lanthanum and the saccharoferric oxyhydroxide. 5 questions to be answered. Can phosphate binders be taken without food? The answer is, it is better to advise that phosphate binders are either to be taken immediately before eating or with food. Because if they are taken on empty stomach or many hours after eating, what will happen? If we take calcium-based phosphate binder, this will be associated with positive calcium balance and will reduce the capacity to bind phosphate because we are away from food. Why would a dose be missed? This is to be investigated to enhance the adherence. But if the patient missed a dose, we shouldn't say to him, you should take double the dose in the next time. No, I should investigate why he is not adherent to the treatment, and to enhance adherence and follow his adherence, and we shouldn't double the dose in the next time. Should chewable tablets, such as over-the-counter calcium carbonate, be chewed or swallowed whole? Chewed tablets should be chewed because this will give the highest phosphate binding. With the exception of saccharoferric oxyhydroxide, can be splitted into small and then absorbed, then swallowed. Should phosphate binder be personalized? Yes, according to the patient characteristics and hypercalcemia, positive calcium balance to avoid calcium-based phosphate binders. In the presence of calciphylaxis, yes, we avoid calcium-based phosphate binders. In the presence of iron deficiency, this is a trend to ferric citrate. Some trials about the different aspects of phosphate binders. This is a very interesting study. Here, the cardiovascular outcome of calcium-free versus calcium-based phosphate binders. Calcium-free phosphate binders are expensive. So patients here, 65 years on dialysis. The question, is the calcium-free phosphate binder, sevelamer carbonate, associated with superior cardiovascular endpoints compared with calcium acetate in patients 65 years or older with end-stage dialysis? This is the number of patients in each arm. This is a cohort study. This is a collection of the data. It's not randomized controlled study, but as you see, the number of patients is sufficient to have comparison. No difference regarding cardiovascular or mortality. So this null result suggests that any potential increased safety of sevelamer compared with calcium-based phosphate binder on cardiovascular event observed in previous small trials, because in previous small trials or few data, few patients, sample size is limited. This is a big sample size showing no real difference. Why? Because the treatment is not phosphate binder alone. We should treat the patient as a whole and targeting different axes, as I am going to discuss. Does sevelamer protect the kidney and reduce proteinuria? This was the result of ANSWER randomized trial. The simple answer for this small sample size, sevelamer doesn't reduce proteinuria. What about ferric citrate? This is the meta-analysis of 16 studies assessing ferric citrate for the management of hyperphosphatemia and iron deficiency anemia. And the main results, ferric citrate is potent phosphate binder with positive advantage of replenishment of iron in dialysis patients. The major side effects are diarrhea and discoloration of feces. And this is the comparison between ferric citrate and the ferrous sulfate. And as you see, the ferric citrate was associated with increased the iron states, iron transference saturation and ferritin. So this is advantage. What about saccharoferric oxyhydroxide? Yes, the sample size here is not big, but this is a very nice study. Using this type of saccharoferric oxyhydroxide, in comparison to the baseline, as you see here, there is significant improvement in phosphorus. The lighter color means phosphorus less than 5. At the end of 3 months, the majority of patients from 62% changed into 92% with controlled phosphorus. In comparison to other phosphate binders, it is significantly associated with higher efficacy on phosphorus. The second advantage of this molecule is the number of tablets. After 3 months, 2.3 tablets, but the other phosphate binder is around 6 tablets. So it is more effective with fewer number of tablets. When it was used as chewed tablet, there was disagreement to use, but when you change it to cut in small pieces and swallowed, the majority like it. And another data, this is experimental in animal studies, showed that this drug protected the kidneys against the fibrosis. So this is another advantage. And from my point of view, one of the best advantages of saccharoferric oxyhydroxide is reduction or prevention of increase in serum FGF23, which is associated with many comorbidities. How to target phosphate absorption. So targeting phosphorus is regulation of diet, phosphate binder, and then the third point is absorption. This is one of the editorial comment, BITs. What is BIT? If we look at the intestinal cell, this is the intestinal cell, and these are the two major routes of phosphate absorption by the intestine. Active transport through the cell, so transcellular absorption is active transport, and the paracellular pathway of phosphate absorption is passive one. So transcellular transport through different transporters like sodium phosphate 2B transporter, BIT1, and the BIT2 transporters. Nicotinamide or niacin block this sodium phosphate transporter, and there is a very nice randomized controlled study about niacin plus phosphate binder I'm going to mention in a minute. Then we have drug that inhibits sodium hydrogen exchanger. By inhibition of sodium hydrogen exchanger by tinabanor, it blocks the passive transport of phosphorus. So how to target the intestinal absorption of phosphorus is either by blocking these transporters or inhibiting the paracellular pathway. Is there any randomized controlled study? Yes, this is a very fantastic study done for patients with CKD, C3B and 4. So it is non-dialysis patients, 4-arm parallel group, double-blind, strong randomized controlled trial. This is the first arm nicotinamide active. This means the patient receives the nicotinamide. Lanthanum active. This means that the patient has both. The second arm, nicotinamide active and the placebo lanthanum. Third arm, reverse, nicotinamide placebo and lanthanum active. The fourth arm, both of them are placebo. And it is double blind. Both treating physician and the patient don't know. I was eager to know the result of this randomized controlled study. And I was expecting a fantastic end of the study. However, it was negative study. The use of nicotinamide plus lanthanum doesn't add anything. Why? Because of tolerability, because of increased gastrointestinal side effects that lead to intolerance to the drug and stopping of medication. This is why this was a negative study. This is the study of tinabanor, which inhibits sodium hydrogen exchanger that block paracellular reabsorption. It was a randomized phase 3 trial that was published last year, in the JSON, showing in comparison to placebo, different dosages of tinepanor was associated with significant reduction of phosphorus even after 4 weeks of a stoppage of both drugs. Still phosphorus, the increase of phosphorus is still marginal in tinepanor treated patients, and in placebo there is significant increase. So tinepanor significantly reduced the elevated serum phosphorus in patients on hemodialysis with hyperphosphatemia in this study. By the way, the most important side effect of tinepanor is diarrhea. This is why FDA approved tinepanor for treatment of irritable bowel syndrome outside renal failure. This is irritable bowel syndrome of constipation type, because some patients have just severe constipation that responds well to tinepanor, because tinepanor leads to excessive loss of sodium and phosphate within stool. So tinepanor may be of value for severe hyperphosphatemia in dialysis patients. And just a notice, it is not recommended in children. Why? Because in pediatric, there is safety reason in pediatric patients. What about EOS789? This is a pan-phosphate transporter inhibitors. It inhibits all the sodium phosphate transporter, so inhibit all transcellular transporters of phosphate. It is fantastic in the experimental animal model. So here it blocks all these transporters, so it blocks a transcellular pathway with significant reduction of phosphorus and its complications. So it provides beneficial effects against hyperphosphatemia and its complication by the strict restriction of serum phosphate. And it was tested in volunteers and phase 1 human studies in dialysis, and it shows a very nice potentials to be tested in large studies, and we are waiting further studies. Although we have diet and phosphate binders and drugs to inhibit absorption, and we have dialysis for dialysis patients, still we have unmet needs, and we have a lot of questions that are awaiting further randomized controlled study. The second axis of treatment is vitamin D and vitamin D receptor agonists. These are the different forms of vitamin D and the active vitamin D. And this is I like this slide because for D2, the parent compound is ergocalciferol. There is some preference for D3, which is cholecalciferol. So D3, and I think Professor Riyad Saeed likes the vitamin D3, cholecalciferol. And if D2 is activated after first hydroxylation, we have ercalcidiol. And after second hydroxylation, we have ercalstriol. For vitamin D3, we have cholecalciferol and 20 hydroxy vitamin D3, which is calcidiol, and 125 dihydroxy vitamin D calcitriol, plus the analogs like calcitol and doxycalciferol. Okay, this is a case, and I like to read it with you. This is a 61-year-old man with a stage 4 CKD. He has autosomal dominant polycystic kidney disease. It's okay. Let us look at creatinine is 2.6, calcium is 9.2, phosphorus is 4.2, albumin 4.1, beta H is 228 picogram per milliliter. This is hyperparathyroid. And 25 hydroxyvitamin D is 18 nanogram per ml. So if you go to this article, and this is very nice because it is kidney case conference, how I treat. It is like the cases that is presented by, are presented by Professor Riyad Saeed, this is a teaching case. If we have this case, stage 4 CKD, with evident vitamin D deficiency, if we treat vitamin D deficiency, I think the case can be improved. And this is what happened. They treated vitamin D deficiency by vitamin D, and after replenishment of vitamin D level, what happened? Beta H goes down and everything was fine without complication. So this is an important point. Why it is important to look at vitamin D? Look at this data. These are the patients with reduction of GFR, PTH increases if we take all the patients in one assessment. But if we categorize them into patients with vitamin D deficiency or repleted vitamin D, look here, with vitamin D deficiency, the curve of PTH is very high. But if vitamin D is repleted and there is no non-vitamin D deficiency, this is a green color, you will find here a step gradual increase of parathormone, not like this very accelerated rise of PTH. This is why to put vitamin D in mind and to be corrected. What about baricalcitol, Zembler versus calcitriol in dialysis patient? This is the comparison based on meta-analysis of randomized controlled trial. The conclusion, baricalcitol and calcitriol provide comparable clinical effects for dialysis patients. The proposed advantages of baricalcitol is the lower risk of hypercalcemia that was not found in the real life. So they are comparable regarding the adverse effects. Everything is the same. So in United States, the first treatment of hyperparathyroidism is IV vitamin D receptor analogs. So they discuss here conversion from intravenous vitamin D analog to oral calcitriol in patients receiving maintenance hemodialysis, 2,000 or more in each group. And if we look at the three parameters, calcium, phosphorus, and PTH, there is no difference between IV and oral, and there is no difference in survival between IV and oral. So we can change, as you see here, it is a retrospective cohort, 2,000 in each arm, 45% within the target, PTH, calcium, phosphorus in two modalities. They are comparable, no difference between IV and oral. Vitamin D in CKD, this is a very nice review about the role outside PTH control, adequate magnesium, and this is an important point. We don't like hypo and we don't like hypermagnesemia in CKD patients. We may allow some or permissible hypermagnesemia in dialysis, but not for CKD patients. So adequate magnesium level are essential for vitamin D. So if we replenish magnesium, this may increase even vitamin D level. We need a large randomized control study showed that vitamin D supplementation has no effect on cardiovascular, albuminuria, or progression. So the randomized control studies are negative. High-dose cholecalciferol and other vitamin D formulation don't appear to increase the risk of stones, but it's wise to monitor urinary calcium excretion as shown here. Uncertainty still exists about optimal 25-hydroxy vitamin D, but I don't like low level. Oral alpha calcidol, is it fantastic drug? This is the randomized controlled trial. Effect of oral alpha calcidol in clinical outcome in patient with secondary hyperparathyroidism. It is a randomized controlled study, more than 400 patients in each arm. The question, does treatment with active vitamin D reduce cardiovascular risk in patients undergoing hemodialysis? The answer is no difference. No difference in cardiovascular disease or mortality. The fourth item is calcimimetics. This is from pediatric European renal data, renal era, European Association editor, position statements for using Senecalcet in pediatric patients. These are the point, and I think it is the same for adult except the dose. So they recommend serum calcium, phosphorus, PTH, and vitamin D level to be regularly monitored, and we like this point. The evidence is fine. Recommending that albumin-corrected calcium, this is what we do. We are nephrologists. Either corrected calcium by looking at serum albumin or ionized calcium. Recommending serum calcium and the phosphate to be kept within the age-appropriate normal range. So if calcium is low, this is a contraindication for Senecalcet. suggesting that Cinacalcet is used in children above 3 years with persistent hyperparathyroidism. No clear threshold of PTH above which Cinacalcet should be started. Don't start Cinacalcet in patient with albumin with calcium less than 8.8 milligram per deciliter or 2.4 millimole per liter. Don't start Cinacalcet in patients with prolonged QT, so we need ECG. Recommend that Cinacalcet is used with caution in patients with history of seizures, arrhythmias, significant liver disease, poor adherence, suggesting that drugs that prolong QT, like antiemetic drugs, to be avoided or to be given cautiously for the patients on Cinacalcet. Starting dose and escalating the dose according to reach the target. And the same for reducing the dose. I'm not going to read all these. So let us go to the drugs. What are the list of the drugs that are contraindicated if the patient is treated with Cinacalcet? All these drugs, either because of potential to increase QTc or inhibitor of cytochrome system, and Cinacalcet is metabolized by cytochrome system. So this list of the drugs and other drugs to be cautiously used with Cinacalcet or contraindicated. What about other members? In adults, this is etylicalcetide that is given at the end of each dialysis session. So it's given 3 times per week. So the results of 2 parallel phase 3 randomized placebo-controlled trial, including more than 1,000 patients, showed efficacy in reduction of parathormone. And this is the difference between Cinacalcet and etylicalcetide. Both of them are calcimimetics. Cinacalcet is the old one, approved in Europe in 2004, and this is in 2016. The mode of action, I'm not careful about the mode. At the end of the day, it is stimulating of calcium sensing receptor. It is, Cinacalcet is given daily oral. This is intravenous at the end of dialysis session. And the question, why at the end of dialysis session? Because it is dialysable, to put in mind. This is the half-life, excretion. This Cinacalcet interacts with drugs that interact with cytochrome system. But for the intravenous etylicalcetide, no significant interaction. This is a starting 30 milligram starting dose of Cinacalcet to be increased up to 180 milligram. And this is the dose for the comparable drug. The efficacy in the point, this drug, the intravenous etylicalcetide, is more potent for controlling of parathormone. Another member is added by Japanese in 2018, which is Evocalcet. Evocalcet is admitted because of better safety, less nausea and vomiting with Evocalcet, as shown from Japanese study. So the side effects is less with Evocalcet. This table summarizes the difference between the 3 types of calcimimetics used in adults: Cinacalcet, etylicalcetide that is given intravenous, Evocalcet. As I mentioned, it is 60% this drug removed by dialysis. This is why it is given at the end of dialysis session. Is there any comparative analysis between all calcimimetics? This is the very nice network meta-analysis, included 36 trials, 11,000 participants, and this is how they presented the data, either for controlling the parathormone or the side effect of hypocalcemia, because this is the most important side effect of calcimimetics. The size of the node reflects the number of patients. So here, this is the number of participants big. If the intervention is connected through line, this means that there is direct comparison between Cinacalcet, for example, and placebo here. This is the number of trial, and this is the number of participants in each of them. Okay, what are the results? Regarding PTH target, which is the efficacy-wise, we want to treat hyperparathyroidism. Cinacalcet achieves 50% efficacy, or 48.9%. Etylicalcetide, 77.8%. It is more potent than Cinacalcet. If Cinacalcet is given with vitamin D, 48 increased to 60%. Evocalcid has better tolerability, but less efficacy, to put in mind. So this is vitamin D. This is how vitamin D work, and you can look at is the peak in the best or the worst. So for example, ethyl-calcitide here, the peak is near the best. This means this is the best drug achieving efficacy for controlling birth hormone. For side effects, hypocalcemia, this is the worst here. The peak is toward the worst for ethyl-calcitide. This means that it is the most potent, but it is the more associated with hypocalcemia. Nausea. Cinacalcet is associated with nausea. This is a problem. And I am going to discuss with you why it's associated with nausea. Here, nausea is less. Here, again, there is nausea, but less than cinacalcet. This is regarding gastrointestinal side effects comparison and how to reduce the risk of nausea. So nausea is very common with cinacalcet. Give cinacalcet with main meal. This is what we advise for the patients. Give it to take it at the end with main meal after dialysis in the evening. Decrease or fractionate the dose, and starting with a smaller dose and increase the dose gradually. Symptom appear after a dose increase. Caution is advised with anti-emetic, because anti-emetic like metoclopramide or perimperan is associated with prolongation of QT interval. So to be cautious about that. So this is nausea is very common, vomiting is very common, and this will reduce the tolerability of the drug and the failure of the treatment. Hypocalcemia, is it common? And if hypocalcemia is serum calcium is below certain target, suppose that we say total serum calcium is 7.5 milligram per deciliter. It's contraindication absolutely for calcimimetic to consider this. The use of concomitant vitamin D may help to guard against occurrence of hypocalcemia. Regarding ethyl-calcitide, the most potent calcimimetic, there is some caution about the use of this drug in diabetic patients under hemodialysis. Why? Because it increases the risk of hypoglycemia, interfere with antidiabetic drugs, and increase the risk of hypocalcemia. Do we know everything about calcimimetics? Still, we don't know. One of very interesting explanation of nausea and vomiting with cinacalcet is cinacalcet activate calcium sensing receptor within the gastrointestinal tract. So this is one of the mechanisms. Or passes blood-brain barrier, so it may be central effect. So why we have nausea with intravenous drug? So still we need to know a lot about these points. But again, calcimimetics, if they are used properly and the patients monitored well, may have other advantages in the bone, as mentioned by Dr. Amr. What are the comparison of different drugs? If you look at vitamin D analog, in comparison to cinacalcet, ethyl-calcitide, evocalcet, the beta H here is reduced by all these drugs, and ethyl-calcitide is the potent for controlling birth hormone. But in the same way, it is the potent to increase hypocalcemia. Vitamin D protects against hypocalcemia and be associated even with hypercalcemia. This is why we should monitor. The problem is vitamin D is associated with increased phosphorus as well, but all calcimimetics are associated with reduction of phosphorus. FGF23 is reduced by all calcimimetic, and another here, this is a problem of vitamin D increase FGF23. We don't like FGF23 to be elevated anymore. So this is the difference between these drugs. So if we have a patient with hyperphosphatemia, hypercalcemia, and high beta H, the best treatment is calcimimetic, and it is considered as medical parathyroidectomy. But if we stop the drug, everything will go back to its effect. So what about parathyroidectomy? And we have Professor Ahmed Halawa. This is a very difficult surgery, need the professional surgeon who mastered the technique. in a patient with multiple comorbidities, but if it is indicated, it is the last resort if medical treatment fail or there is critical indication, as I am going to mention. When I presented this abstract in the ESOT last year, the question of this lady that was a chair, when we should do parathyroidectomy, and the answer was the last resort. This is a very recent atlas for surgery of the parathyroid gland, and this is from another book about the indications of secondary of parathyroidectomy in the era of Calcimimetics. When secondary hyperparathyroidism is refractory to vitamin D analogs and Calcimimetics, when quality of life is highly impaired due to severe hyperparathyroidism, when the Calcimimetics fail, okay, or intolerated, or if the patient has thyroid disease, cancer, and here we will do a thyroidectomy, so parathyroid is indicated. Or if we are dealing with secondary hyperpara and the gland by ultrasound is big gland, the diameter exceeds 1 centimeter, the likelihood of response to medical will be low, but I encourage starting medical treatment before thinking of surgery. The critical indications for surgical parathyroidectomy is deformities, ectopic calcification, neuromuscular psychiatric symptoms. So it is failure of medical treatment, heart failure, severe osteitis fibrosa, and calciflexis. This is one of the patients with calciflexis, and this is the valve calcification of the vessel. You see here clearly calcified vessels in the hand. After 1 year of surgery or parathyroidectomy, calciflexis disappeared. We have different approaches, either subtotal, and these are the advantages and disadvantages. I'm not going to discuss them because we have the Professor Halawa and he can comment about total, subtotal. By the way, if we have total, this means the total with autografting, because we don't need beta H to be 0 because it will be associated with a dynamic bone disease. So each modality has its merits, advantages, and disadvantages. The long term, this is one of the publications of Professor Ahmed Halawa about the long-term outcome and the management consideration after parathyroidectomy. He mentioned clearly in one of the tables that parathyroidectomy was associated with survival advantage. So this is the last resort if medical treatment fail or if there is problem in the bundle of support. This is one from other source. This source considers parathormone as toxin, uremic toxin, associated with many comorbidities, hypertension, myocardial hypertrophy, abnormal bone density, increased level of cytosolic calcium in the brain, synaptic terminals, hemolytic dysfunction, resistant anemia, reduction of T lymphocytes, increased all-cause mortality. All these improved significantly by parathyroidectomy. One of very interesting questions, if we have severe hyperparathyroidism and the patient will be transplanted, and hyperparathyroidism is not corrected by medical treatment, beta H is 2000 persistently, despite we use all the modalities that we can use and escalate the dose. To do parathyroidectomy before or after transplantation, these were the articles, and what I am convinced is to do it before transplantation. Why? Because this is one of the publications showed that in the blue color means parathyroidectomy is done after transplantation. The red color means before. If you compare this is a graft function. After 48 hours, graft function is better if parathyroidectomy is done before transplantation. Why? Because if we leave the patient with severe hyperparathyroidism, this will affect the graft adversely. And this is the calcium deposition with injured renal tubules because of severe hyperparathyroidism. And these are the indications of parathyroidectomy after transplantation. And in this source, they consider tertiary hyperpara if it occurred after, if it persisted after kidney transplantation. And these are the indications: persistent hypercalcemia, low bone mineral density, renal stones, deterioration of kidney graft, symptomatic hyperpara, bone pain, and others, enlarged parathyroid gland by ultrasound. These are indications of parathyroidectomy after transplantation. KDIGO guidelines The guidelines, we have two versions, 2009 and 2017. Professor Ahmed Hussein elegantly demonstrated in one of his visits the difference between 2009 and 2017. What happened in 2017? If you compare the evidence here in 2009, we have 2 in 1B. We have 0 here. So the evidence is declining because of the negative results of the studies. And so the KDIGO 2017 added to the complexity, and we are waiting further refinement. But I'm going to just to read with you the lines of management of hyperparathyroidism based on the KDIGO guidelines 2017. In patients, this is regarding BTH. In the patient with stage 3A to stage 5, not on dialysis, the optimal BTH level is not known. However, the KDIGO guidelines suggest that patients with level of intact BTH progressively rising or persistently above the upper normal limit for the assay be evaluated for modifiable factors. This is what we should do for CKD before dialysis. If there is hyperphosphatemia to control phosphate, there is hypocalcemia to control hypocalcemia, the vitamin D deficiency to give vitamin D, like the case I presented from the literature. In adult patients with a stage 5, 3A to 5, not on dialysis, suggests that calcitriol and vitamin D analogs not be routinely used. It is reasonable to reserve the use of calcitriol and vitamin D analog for patients with CKD, stage 4 and 5, with severe and progressive hyperparathyroidism. So if we have the patient before dialysis and after correction of vitamin D deficiency by native vitamin D, controlling phosphorus, and still there is acceleration of parathormone, we can use vitamin D analog receptor activators. In children, calcitriol and vitamin D analog may be considered to maintain serum calcium to the age appropriate. In patients with on dialysis, suggesting maintaining intact BTH in the range of 2 to 9 times, and this depends upon the serial and the follow-up of the patients, suggesting that the marked change in BTH, either up or down, necessitate marked change in medications used for these patients. And the treatment of hyperparathyroidism are dependent upon calcimimetics, calcitriol, or vitamin D analog, or combination of them, calcimimetic with calcitriol or vitamin D analog. In patients with stage 3A to 5D with severe hyperparathyroidism who fail to respond to medical treatment, surgical parathyroidectomy is suggested, and this is the level of evidence. The last 10 minutes, I'm going to present some new in the horizon. This is one of the advances of the phosphate binder, combination of ferric iron oxide and dietary ligand adipic acid. Adipic acid is present in the beets, البنجر. The combination of ferric iron oxide and dietary ligand adipic, what happens? Adipic is changed with phosphorus, so it takes phosphorus. It is expected to be more effective in controlling phosphorus. And this is the result of phase 2B study. It showed here with the different dosages of this BT20, different dosages were associated with significant reduction of phosphorus, and it is tolerated. Regarding sevelamer, as I mentioned, some of disadvantages of sevelamer is its affection of vitamin K. So sevelamer may lead to vitamin K deficiency. So this is the difference between sevelamer user and not users. And here sevelamer is associated with disturbance of gut microbiome, reduction of vitamin K, and increasing uremic toxin, endoxyl sulfate, cressyl sulfate, and others to put in mind. And this may explain why the use of sevelamer doesn't improve survival. So long as I mentioned the gut microbiome, is there a relationship between gut microbiome and the parathormone? This is a very nice digest of the current issue of Kidney International. Showed that gut microbiome orchestrates the action of parathormone. How? This is the gut microbiome. If it is healthy with sufficient butyrate, or the patient receive short chain fatty acid, everything is fine, butyrate is good. What happens? the pulsatile PTH increases T regulatory cell and stimulate osteoblast with bone formation. This is the scenario. But in chronic kidney disease, there is dysbiosis with reduction of butyrate. Reduction of butyrate shift in the presence of continuous stimulation of parathormone in the presence of CKD, shift the reaction toward from T regulatory cell to inflammation and the monocyte macrophage and stimulation of osteoclast and the bone resorption. It means that healthy gut microbiome is essential for bone formation. So this is another point toward kidney gut bone axis. From where they extrapolate the data in this digest from this very sophisticated study that is published in this journal, prestigious journal, parathormone dependent bone formation, and this is elegantly showed by proteomics and the sophisticated techniques that the presence of butyrate is essential for the T regulatory cells and osteoblastic and Wnt pathway, and in disturbance in uremia was associated with osteoclast formation. Another interesting point is circadian rhythm to put in mind when to look and what happens to the physiology. This is a normal person. PTH is showing rhythmic oscillation. And you can see here the difference according to day and night. And this is in CKD. What happens? Flattened, elevated PTH in renal and CKD. FGF23, the oscillation is also reduced. Activin A also, there's a problem in circadian variation. This may open the horizon for drugs working on this, or we take care of this in our mind when we look at the lab. So calcium, phosphorus, PTH, and all these parameters have a circadian variation. This is the FGF23 pathway and the concept of iron as phosphate binder. Simultaneous management of, if you look here, hyperphosphatemia with CKD, the presence of iron deficiency or iron deficiency anemia. So we should look at iron for CKD patients because iron deficiency increases FGF23 expression, increase phosphorus, increase the genetic expression of FGF23. So both of them increase the issue. If we look here for the curve of the CKD, looking at if we use ferric citrate, everything is, the level is improved because it improves both the circulating and intact. And I think it is clear here. In the presence of anemia and hyperphosphatemia, FGF23 is elevated with bad consequence for kidney and heart. But if we use ferric citrate, it will reduce phosphorus and correct iron deficiency and reduce FGF23 and reduce hypertrophy. So greater long-term exposure to elevated FGF23 is bad. Hyperphosphatemia, iron deficiency, and anemia in CKD contribute to excess circulating FGF23 to put in mind, and the ferric citrate may be the drug of choice. FGF is bad. Another article documented, this is the very nice cohort study in CKD, not on dialysis patients. This is the number of patients included, more than 3,600 patients. 29% of them were hospitalized because of infection. And the infection was correlated with very high level of FGF23. So it is U-shaped curve, very low level and very high level were associated with infection, irrespective to the demographics studied. So among individuals with CKD, higher FGF were associated with an increased risk of hospitalization with infection. Which type of infections? All infection. The most frequent, UTI, followed by cellulitis, osteomyelitis, pneumonia, and then bacteremia and septicemia. How to handle FGF23? It seems that correction of anemia has positive impact on the FGF23, positive effect. So erythropoietin and hypoxia inducible factor stabilizer, prolyl hydroxylase inhibitors, both of them reduce the FGF23. In the X-linked hypophosphatemia, that the disease that is linked with severe hypophosphatemia because of excessive FGF23, was successfully treated by Denosumab, which is monoclonal antibody, human monoclonal antibody against FGF23, was efficient treatment for X-linked hypophosphatemia. But we still, up to this moment, it is not tested in CKD patients because we don't have studies for that. Denosumab, this is an interesting study, showed this Denosumab Prolia was associated with a reduction of vascular calcification through this small sample studies. The last point, Klotho, because Klotho is deficient in CKD, and this will appear in January next year in this journal. The potential beneficial effect of Klotho is cytoprotection of the kidney, antifibrosis, improving phosphorus, reducing vascular calcification, a lot of beneficial effects. So are waiting further evidence. The last 2 slides. What about secondary hyperpara from the management point of view in different countries? I think, Professor May, this is very interesting to have our data, and I should congratulate the preliminary efforts done by Professor May and Dr. Tantawi about this point, because here, these are the different countries, and we can know the percentage of Cinacalcet use, phosphate binder, intravenous vitamin D, or oral vitamin D. If you look carefully, you will find the majority of countries used phosphate binders. But regarding intravenous vitamin D, here in the United States, they prefer intravenous vitamin D for treating hyperparathyroidism. Cinacalcet, here you can find the Spain, 34% of the patients used the Cinacalcet. So other countries in Europe used oral vitamin D. This is the detailed treatment, oral, and the type of alpha-calcidol, calcitriol, baricalcitol. For example, baricalcitol is used in Spain, 87%, and United States, 45%. These are the baricalcitol users. This is the different drugs, calcium base, sevelamer, and others. Even dialysate calcium. This, if we look at this slide, because dialysate calcium affects the calcium level in the blood. And here, if you look here, for example, Saudi, here 67, this is green color. Green color here means that the calcium in dialysate is 1.5 millimole, 3 milliequivalent per liter. And 32 use 3.5 milliequivalent per liter. So this is, if we look at this data, this means that in Saudi, they should change this 1.75 millimole calcium because it is very high. If you compare, for example, if you were in Japan, there is Japan, nothing, no 1.75 because it is bad. So this is, the messages can be taken from the data. This is what I present today, but still there are a lot of unknowns. This means that we should learn, study, to have research. And always I mention, doctor is a student till his death. When he fails to be a student, he dies, or the doctor inside him dies. And this is why we established this virtual academy that is now very rich, more than 4,600 lectures, 1,800 videos, with the collaboration, as Professor Riyad and Professor Sobh mentioned in the beginning, and Professor May, all the experts in the field within Egypt and Arab world and international country, international friends and experts shared for the reach of this site. At this point, thank you very much, and I know it was very long presentation, and I am ready for your questions. Dr. Saeed. Al-Hadidi, please unmute Dr. Saeed and Dr. May. I stop here the chair.
Excellent presentation, Professor Hussein, actually, as usual, and we learned a lot from this. Any one of the elegant audience and our professors wanted to comment after Professor May? Okay, we are ready. Please, Professor May. Please unmute here, Dr.
She is unmuted. قربي من المايك يا دكتورة مي.
الصوت مش مسموع يا دكتورة مي.
I thank you because this was really very much updated and informative, and I'm sure everybody learned a lot today. So we just open the field for discussion. Okay.
Dr. Talat Antawi is the moderator also. Thank you very much for this gathering.
هو الدكتور سعيد ماسك المايك وبقى يعني عمال يعني
It's okay.
مفيش فيرنس خالص يعني.
لا يا باشا.
هو في كذا كومنت. المحاضره طبعا واضحه جدا وكلير، لكن في كذا كومنت. What do you mean by pulsatile PTH؟ يعني هي حاجه لها علاقه diurnal ولا لها علاقه بالليفل بتاع الكالسيوم والفوسفورس؟ السؤال الثاني، البي تي اتش ليفل حضرتك عارف السي كي دي دي احنا بنتكلم على 2 فولد و 9 فولد من البي تي اتش ليفل، لكن ما فيش كونسنسس اباوت اللي هو السي كي دي براير للستيج اوف داياليسيس، ولكن طبعا وي ار نوت الاو ان يبقى في ترند للاليفيشن او فيتامين دي ديفيشنسي او هايبوكالسيميا او هايبرفوسفاتيميا. انا بس عايز حضرتك، لان طبعا المحاضره كانت ريتش بالداتا، ودي نقطة مهمة جدا في البراكتس بتاعنا.
Okay. Thank you very much, Dr. Tariq. Very nice questions. Regarding pulsatile nature, there is a difference between pulsatile and circadian rhythm. Circadian rhythm means that the level is high in the morning or in the evening. That is the level, but the level is continuously present. The problem of phosphate, if it finds a stimulus, like for example, it is burst, like burst, and then stop. So it's seconds. Half-life is seconds. This is why it is not like thyroxine to be given as maintenance if you have hypoparathyroidism. And this is a great if the problem of hypoparathyroidism, and we have Professor Halawa after parathyroidectomy, is treated by parathyroid replacement, this will be fine. But teriparatide is given even for to stimulate the bone, but not for to replace PTH, because it doesn't replace. So pulsatile means it is of very short half-life, pulsatile nature, and they dropped suddenly. Circadian rhythm means that we have level, but there is smoothness of the curve through the day and night. Regarding your point, 2 to 9 fold, I agree with you 100%. And I said to you, we should know the limitations of PTH measurement, because C terminal concentration may be the dominant one. This is why if you say PTH for this patient is 300 picogram per ml in dialysis. So this is hyperparathyroidism. I should increase vitamin D, sinacalcet, ATC. What the patient may suffer from problems because C PTH is inhibitor to the bone. So the patient may have adenoid bone disease. But if it is today 300 and tomorrow 600 or the next level 600, this is a change. This is why KDIGO guideline changed their mind toward trend. And the trend not only for PTH, we should normalize phosphorus, calcium, and not normal PTH. It is higher than normal if we are in CKD stage. Before dialysis, this is another point, but in dialysis, 2 to 9 according to the patient status and according to the patient trend. If your patient is attaining 3 values of the normal, but is stable on this is his target. But if you follow the patient, so the magic message is to serially monitor PTH and looking at the trend, not only one measurement. And another point in extension to our private discussion, if you have 300 becomes 900, we should increase the frequency of testing. Even we can test after 1 month. And for calcium and phosphorus, instead to be monthly, weekly to be measured. And after stabilization, I go back to the frequency rhythm that is recommended or suggested by KDIGO or China or Egypt or whatever the authority. So they are very valuable questions. دكتور سعيد، دكتور فيصل ريز
حضرتك المانجر الكبير يا باشا بالعفو.
دكتور فيصل رافع ايده ريز
دكتور فيصل كان ريز هاند. اتفضل حضرتك يا دكتور فيصل بيه.
اهلا مساء الخير. I enjoyed the talk very much, Prof Hussein.
Thank you very much.
I have two points. I mentioned before that we did one study, which is observational study in all Middle East about CKD-MBD. The name is OCNAS study, and it's been published And it shows, it answers many of the questions you raised about the behavior of the doctors, patient, and how they follow up of their patient and how they manage their patient and what's the recommendation for them. This OSINA study, it is 15 countries or more than 15 countries with 2,340 patients. I was head of that study, and it gives a lot of information about CKD-MBD. I'll be happy to share it with you, probably, since you are upgrading, like everyone, brilliant, upgrading the talk every now and then. I would like this study to be included as well, because it reflects whole our behavior, even in Egypt, because some people from Egypt with us in this OSINA study.
So we are eager to know from you the detailed study in one of our meetings, inshallah.
Okay.
But regarding the behavior, it is very nice to look at the patient, and if the patient achieves the target of both calcium, phosphorus, and beta-H, even if it is achieved partially. So because if the patient all the time out of the range, the patient will have many consequences. If the patient partially attains improvement in the target, this is better than who don't achieve any improvement in the CKD-MBD profile. But today I was restricting my talk to the parathormone or the vicinity of hyperpara.
Yeah. This was the aim of the study mainly, is to give recommendations about how to follow up the patient, what the management, and it is, you know, it was very important. The second thing about DOPS study. DOPS study also I am starting from, since we started in Saudi a long time back about DOPS in Saudi, then expanded to all GCC countries. And I agree that still we have a lot of defect which we should target in our Saudi patient and GCC patient as well. So we published data, me and Saeed and Wakil and others, about the DOPS, which we started many years back. And still there is a defect, either in Saudi or not. Still the people are not targeting like KDIGO, what their recommendations exactly. And we hope that we can reach at one stage that we target the patient according to what's good for them.
It is very nice to hear from you about these points, because, and this is the advantages of presence of data. And I think the initiative steps by, conducted by Professor May and her team and with Dr. Tariq Tantawi, I think will be on the track. We tried to join the DOPS, but I think it was not there. Still, Egypt, the data is not published yet on the DOPS.
Okay, thank you.
Thank you very much. Dr. Riyad Basha.
مساء الخير.
مساء الفل يا باشا.
As usual, أبدعت. It's really complete and thorough talk. I have really a couple of comments.
Yes,
you mentioned about IV, treatment of IV, vitamin D versus oral. I think the only advantage I'll see for that is the compliance of the patient, especially on dialysis. You know, when you give it to him IV, that usually you ensure that he's taking his medication. The second point, really, you mentioned something about Denosumab, Prolia in dialysis patient. Where we stand with the current situation concerning this?
To use Denosumab?
Yes.
To use Denosumab in dialysis patient is still limited data. Yes. Even the study that I mentioned, the 21 patients in the arm of Denosumab in comparison to the other 21 patients. And it is a good drug because it is given every 6 months. So it is good if it is given within its indications, and not to be used with patients with hypocalcemia or hypovitamin D. So for inclusion of the patient in the Denosumab treatment, we should measure vitamin D. And if there is vitamin D deficiency, we should correct the vitamin D deficiency before. It is associated as Cinacalcet or calcimimetics by hypocalcemia, to be cautious about the hypocalcemia and the monitoring of calcium when we give Denosumab. But it is very nice drug for treating osteoporosis and it helped a lot. But even outside renal failure, it is used for management of hypercalcemia because of this drug targets the rank pathway, so it is efficient for treating malignancy-associated hypercalcemia. And the problem, if it is rapid withdrawn, hypercalcemia may recur and rebound hypercalcemia occur after its stoppage. So to know its pharmacology and you want to use it, it is very nice. But it is used primarily for osteoporosis. And before its prescription, we should be sure that the patient has sufficient vitamin D and normal calcium.
Okay, I think that's great. The second point, really, if you allow me, I was this morning listening to the talk that Dr. Amr, because I missed it really live, and I have a couple of points about really, which is again, I think you mentioned now, parathyroidectomy. And I'm sure Dr. Halawa is going to comment on this. You know, it was a sad story really to have that lady with all the complication of hypoparathyroid, what happened. Now we have similar situation. In fact, we transplanted parathyroid gland. We have good experience with one patient that we have really two transplant and lived with him for almost 3 years. It happened that we transplanted the patient. He was hypoparathyroid to start with. Then we have a kidney transplant. On the same day of our kidney transplant, we have another patient with parathyroidectomy. Okay, so we got permission from the patient and the recipient. We asked them, going to transplant this for you, and we transplanted in his forearm after the transplant, kidney transplant surgery, a piece of the parathyroid of the one who is on dialysis. It worked really for 3 years with a good calcemic level, but unfortunately, after that, it's faded away, its function faded away. I don't know if anyone has an experience like that with parathyroid transplantation.
We don't have experience for parathyroid transplantation, but I read about this topic extensively. There are some case reports published about the parathyroid transplantation, even for patients with the original kidney disease, hypoparathyroidism, because hypoparathyroidism may be associated with phosphate deposition in the kidney and lead to graft failure. And for this case, they succeeded for parathyroid plus kidney transplantation and other case reports. And we thought here to do parathyroid transplantation, but up to this moment, we don't have even single case for this point. And I think Professor Halawa can comment on this point and other points regarding the surgical aspects of parathyroid. Dr. Halawa.
We have one patient only.
Okay.
Thank you.
Okay, thank you very much, Professor Riyad, for your valuable comments as usual.
Thank you very much, Professor Hussein. Actually, I was just interested to listen to to the medical aspect of secondary hyperparathyroidism, and I have few concerns about the practice.
Okay.
Practice for my nephrology colleagues and practice for my surgical colleagues as well. So it looks like there is no ideal treatment because the practice from the nephrology point of view is mainly prevention. And there is a line between prevention and advanced disease. And I can see, can you hear me?
Yes, I hear you well. Go ahead.
Yeah, what happens, I used to see a lot of patients who are already have pathological fractures, have advanced disease and still on senecalcet. And when you look at their profile, no vitamin D was performed for them at all, as if vitamin D is not essential. And then when you requested, you find, vitamin D is 3 or 4, something ridiculous, something very low. So senecalcet is not the first line of treatment. First line of treatment is vitamin D and correct the calcium, and then think of senecalcet if treatment fails. I don't know why, a few of my colleagues jump into senecalcet. It's quite expensive, associated with side effects, not available sometimes. And this is against the guidelines as well. If we are guidelines, adherent, this is against the NICE guidelines, against the KDIGO guidelines as well. So, so this is not the first line of treatment. If the other measures failed, and the patient is not fit for surgery, cinecalcet has a role to play. And this is my concern. You see patients wheelchair bound and still on cinecalcet, vitamin D wasn't checked, calcium level is foot low, which is, of course, this is not right. It's too late now to deal with anything because the gland is massive, and actually it may be not fit even to lie on table. Because the problem with these patients, when they present in advanced stage, they could have iatrogenic fracture. Just mobilizing them from the trolley to the operating table, they can fracture their spine. There's no bone. It is just soft tissue all the way through. And this is actually accounts for the morbidity and mortality as well in these patients. My concern regarding the surgical practice, because I wish I was looking, who's participating in this discussion. I haven't seen a single surgeon. And I wish the surgeon could listen to this talk, because you can change the disease from hyperparathyroidism to a dynamic bone disease, which even worse is associated with mortality, is associated with 5-fold increase in fracture rate. What happens? The principle of a dynamic bone disease I used to explain to my surgical colleagues is basically the lack of PTH, no buffering system. The calcium will precipitate on heart valves, vessels, and the soft tissue. And the bone still will be brittle, easily fractured. So there is a communication link here between the nephrologist and the surgeon. The surgeon needs to know that he should do subtotal, not total, parathyroidectomy, and expecting that there is no 100% cure rate, because we reach an advanced stage now. I don't like to be, we're all friends and colleagues, but parathyroidectomy indicates failure of the medical treatment. They shouldn't come to lie on the operating table. If the patient is compliant and if the nephrologist is aware of the disease, and just do simple measures. So when you reach CKD3, we start measuring PTH, calcium, vitamin D, and start prevention. And actually, in spite of this, in UK, there's a treatment failure as well. Still, we see a lot of patients coming, but not as bad. I haven't seen worse, patient wheelchair bound or pathological fractures here. And the gland I used to see is slightly enlarged fibrotic gland, not like big ones I used to see somewhere else. Also, when the gland becomes massive, and actually you mentioned 1 centimeter, actually, I will take this figure. You can't treat it with medical treatment. And you discover this patient is still on cinecalcet, and still vitamin D wasn't checked. So surgery is not something magic. Surgery wouldn't cure. Also, when you do total and auto-transplantation or subtotal, you leave part of the parathyroid glands or auto-transplant part of the parathyroid glands. This makes the operation more difficult. In what way? Because the part you're transplanting or the part you left behind to maintain a reasonable PTH, you will never know whether it contains a viable parathyroid tissues or not. When the gland becomes bigger, because of the fibrosis, because of the calcification, because of the hemorrhage, because of the necrosis, not because of massive cells. If you look at the normal parathyroid gland, and I will ask, my colleagues guess what a percentage of parathyroid cells in a normal parathyroid gland. I guess a figure. The answer is 50%. So the normal gland, only 50% of it is parathyroid cells. What about the rest? Fat. Imagine when it becomes pathological, So the fibrosis on top of that, the calcification, necrosis, hemorrhage. So the parathyroid cells becomes less. And this makes the auto-transplantation even difficult. So the chances of dynamic bone disease is higher when they come to surgery. Around, I will guess around 25% roughly. So, and these are the concerns which is I pass you today is, don't carry on treating patient medically who is not responding, and try to pick him up as soon as, you know, you got renal impairment and reach CKD3. And hopefully my surgical colleagues will, you know, appreciate that total parathyroidectomy is a crime. It is subtotal, and you have to pray that the PTH will be back to acceptable level. In terms of preventing a dynamic bone disease, it's been reported a dynamic bone disease even with PTH 400. So can you believe it? And it's a disease, again, is difficult to diagnose. It has to be diagnosed by bone biopsy. And reading the bone biopsy, not everybody can read it. You know, they have to be a very specialized center. So again, so there is difficulty in diagnosis of the, you know, diagnosing this disease. So why not to stay away from all this dilemma and prevent the disease? And also for the surgeons, just to be aware that you are committing a sin, committing a crime by removing the 4 glands. But in few occasions, you know, if you found only 3 glands, the 4th gland is missing or is not there, we have to remove the 3 glands with the possibility of a dynamic bone disease and hyperparathyroidism. Thank you very much. Yeah, another comment, I totally agree with you. When post-transplantation, persistent hyperparathyroidism is an indication for surgery. Also, the PTH, there are 2 measurements of PTH, one in picomole per liter and picogram per ml. So we have to be aware of this. So labs sometimes use one of these measures. So we have to be aware of the ranges of these ones. So the picomole per liter is 1.6 to 6.9 to 7, and the picogram per ml is 10 to 60. So if you don't get confused by that. I get confused because I kept asking, is it picogram per ml or picomole per liter? This is my first question because I used to get the PTH is 60 what? So it will give you an indication how severe the disease is.
Okay.
Thank you very much.
Thank you very much, Professor Halawa, for this very valuable comments. We agree with all your points, but I would like to clarify some issues here. Yes, we agree that the best treatment is to start early and to look at the profile, complete profile, calcium, phosphorus, PTH. It is not a welfare. We should do it. We should do earlier because early means early. And I like the statement when I read the KDIGO guidelines carefully. I believe in the statement if the patient CKD is still not on dialysis to control phosphorus and vitamin D deficiency. This may be all what is needed to do. But if the patient on dialysis, the KDIGO guidelines showed that treatment, the first treatment be vitamin D receptor analogs, maybe calcimimetics, maybe whatever. So the nephrologists can use any of them as the first line of treatment dialysis patients so long as the profile is complete. This is why I put the frequency of calcium, phosphorus, PTH, vitamin D in one of the tables of this presentation. If I start early, this may be just native vitamin D, everything will be fine. The issue of parathyroidectomy, I agree with you. It doesn't mean failure of medicine. It is failure of healthy care system in the majority. And when the audit done everywhere, there is a high percentage of patients in different countries, even in the West communities, that there is some percentage of patients outside the range. But if we don't measure the levels and we don't look at serial and interact on serial values, then the situation will be very bad, as sometimes we confront. But likely enough, nowadays, the face of CKD-MBD, I think in Egypt, is improved, even if we don't have the data registry for figures. But nowadays, it is very rare to find uglified or deformities. It's still there, but it's very few percentage that we have nowadays because of doctor orientation and the availability of the lab and early treatment.
Professor Hussein, actually, this is not in tertiary centers, but in other centers, you know, of course, in tertiary centers, they're aware of CKD-MBD, but in other centers where there is no specialized nephrologist, you know, they are not aware of this. And also, something else I would like to highlight.
In dialysis unit, Dr. Ahmed, and I'm sorry for interruption, in dialysis units, they are aware by calcium, phosphorus, BTH. Nowadays, BTH was common, and the majority of dialysis doctors know it. In the past, it was not tested even in very prestigious.
Another thing I would like to highlight, parathyroidectomy is not a treatment of poor dialysis, because what happens, patient is poorly dialyzed, phosphate is high, of course BTH will be high. So, and when when I take a history, how often you dialyze? No, I do good dialysis. Just tell me how many hours? 2.5 hours. To go 3 times. No, but you know, just twice, because you know, I feel sorry. I have a headache, hypotensive, so I'll have to disconnect from the machine. So this is poor dialysis. So expected to be hyperphosphatemic, expected to be have high PTH. So of course, the glands in this stage, it could be hyperplastic. Just might need good dialysis, lower phosphate, calcimimetic, might get better. But the treatment is not the knife.
Okay. Thank you for this point, because you are the surgeon and you said it clearly. That is not knife, it is complementary. We should work in a team, multidisciplinary team approach is not one-man show, not medical or surgical.
Not only that, the patient as well, because you know, patient's compliance is essential, is important. And you know, I've seen a lot of my nephrology colleagues struggling to get the patient back to the clinic because he feels well, that's it really. So he will wait to the last minute till he got broken bone and then seek medical advice. So again, this is compliance issue, which is an essential, and it's a major bulk actually of the health problem is a compliance issue.
Medical, surgical, clinical pharmacist, healthcare system, lab, all this umbrella should be fit to conduct sufficient satisfactory care. دكتور سعيد، دكتور طارق.
شكرا دكتور حلاوه.
كده تمام.
بس في سؤالين دكتور حسين if you allow me.
Okay, yes, you are the boss. You are the boss today.
The normocalcemic secondary hyperparathyroidism. What is the prevalence and the nature history?
Excuse me, normocalcemic?
Normocalcemic hyperpara, secondary hyperpara.
Okay.
It is different from the hypercalcemic in the outcome. I mean, outcome wise. That's number one. Number two, the points always Dr. Tariq raising is this iatrogenic dynamic bone disease from the unplanned prescribing of this vitamin D analogs like on alpha and so from even non-nephrologists and so. Even some nephrologists prescribing without doing calcium, phosphorus, and BTH as by default prescribing this one alpha. So also I need your comment on Dr. Tariq also, please. Thank you.
Before my comment about the first question, even the patients who receive Arabic gum, because Arabic gum contains calcium or increases calcium absorption from the intestine. So we should be cautious about everything we eat, drink, or have medicine. Regarding the calcium, the straightforward is to have hypocalcemia that stimulates hyperparathyroidism. But this is not the situation that we find. We may have hypo, normo, or hypercalcemia. Which percentage actually normocalcemic hyperpara, I don't know. Yeah. But what we should know, we should test them. If calcium is not low or not high, it's good. So this one point, one item. We have phosphorus that should be normalized toward normal. I cannot say it should be 3 milligram per deciliter. It should be toward 5 milligram per toward. Which cutoff point, we don't know. Up to this moment, the gold standard phosphorus, but should decrease toward the target, the normal target. BTH to be within accepted target. And I mentioned we should have the individualized and the personalized target according to the patient profile and the serial monitoring. We don't have fixed value. If you have 2 patients in dialysis unit, both of them have 300 picogram per ml BTH, I may increase Cinacalcet vitamin D analog phosphate binder for 1 patient because the previous testing was 150 and then today 300. If I leave him without changing medication, and the next visit will be 900 or 600. Yeah. So I should start the action now because I find a change in the trend of the profile. And the other patient was 900, 600, 300. If I don't change the treatment, it will go down to a dynamic bone disease and fractures. So I should be dynamic, following up. I don't have the magic bullet to touch the patient to know calcium, phosphorus. But regarding your questions, which percentage, I don't know.
Let me answer this question, Professor Hussein. Actually, normocalcemic hyperparathyroidism is not uncommon.
Yes.
Because the calcium in renal failure patients who have secondary hyperparathyroidism could be normal or low.
Yes.
So it's not common. It's not uncommon. And don't forget, this calcium is coming from the bone because PTH is high. What I need to diagnose secondary hyperparathyroidism is PTH. PTH is high, not imaging. PTH is high, this is definitely hyperparathyroidism. Whether medically manageable or not, I need to check the calcium, vitamin D, and phosphorus. And this actually will give me a guide. Calcium is low, vitamin D is low, treating with calcium and vitamin D. The PTH, will go down. Also, the PTH, you're not expecting patient on dialysis PTH to be normal because, the PTH actually, there is bone resistance to PTH as many other factors. So we are expecting PTH at higher level. We don't know actually, what level is. 2 to 9 by the KDIGO means we don't know. Just, it's all over the place. It's a good guess, So expect it to be a bit higher. How high it is, we don't know. But roughly, I will be not concerned if the PTH is 600. But I will be concerned if above 1,000. This is my personal experience based on no evidence.
Please add to this personal experience, they change the trend.
Actually, yeah. This is actually, you kept stressing on this point, Professor Hussein, which is very important. It is the trend. Because the PTH assay, it measures everything, the C-terminal, NH-terminal, it measures a lot of things, inactive product of, in spite of, it measures the intact. It measures the intact PTH in addition to other products. So the trend, rather than coming to the clinic with one reading and PTH is let's just say 300, now I will ask to check it again and again and again. And this will tell you the trend. And over steady, a long period of time, at least I will know whether this is progressing or not.
Okay.
Regarding second question, Dr. Hussein, regarding the iatrogenic dynamic.
Yes, please.
هو actually طبعا احنا in our daily practice severe secondary hyperparathyroidism actually regressed too much than before. فعلا بقى في اورينتيشن تخص النيوتريشن، واعتقد السي ان اي اللي شغال والمحاضرات بتاعتنا والنشاط النفرولوجي اللي هو اوفر ذا كانتري، الناس بقت عندها بشكل عام وعي كتير جدا موضوع النيوتريشن، موضوع الاديكوسي بتاع الدياليسيس، البروبر يوزج اوف كالسيوم فوسفيت بايندينج فوسفورس، وايفن حتى الاكتيف فورم فيتامين دي او الفيتامين دي انالوجز والسيناكالسيت. الامور اعتقد بقت مور كلير، وهو في مشكله عندنا الادرنس او المشكله اللي هو الشغل اللي هو الشكل المنتظم في المتابعه. هو ده اللي احنا ساعات بنفتقده في بعض الاماكن، واللي من خلاله بنفاجئ بهازارds بقى ومشاكل سيفير سكند هايبرثايرويدزم، حالات اللي هي البراون تيومرز. الحاجات دي ما عادتش كتير زي الاول، بقت الى حد كبير محدوده. لكن ما زال في ابيوز في استخدام الريبليسمنت ثيرابي في حالات السي كي دي، على معتقد الفهم نفسه عند بعض الجونيورز او بعض اللي هم الانترنست او اللي هم بيبريسكرايب، وما فيش حد بيتابع او ما حدش بيلوم حد ان هو ده من الاجنده بتاع التريتمنت بتاعتي. لكن توظيفها واستخدامها في بعض الناس معاك يا دكتور سعيد تماما مش واضحه عندهم وما يشكل. لكن بشكل عام اعتقد الدنيا افضل وبقت الامور واضحه، واستخدام الادويه بقى فيها نوع من انواع الوضوح، واعتقد الدنيا افضل بكتير. احنا طبعا السقف بتاع الطموح عندنا في الهيلث كير مالوش حدود ومالوش افاق، وان شاء الله الخير ان شاء الله.
If you allow me, Dr. Tariq, Dr. Saeed, I want to stress about the calcium issue more and more, because we don't find hypocalcemia except if it is a complication of drugs. In the majority of patients, we don't have an agreement of Dr. Halawa that normocalcemia is not uncommon, it's common. And this is why the KDIGO guideline stressed upon avoiding a hypercalcemia by using vitamin D analogs. So we should monitor. The second, before vitamin D analogs, we should check calcium. Number two, dialysate calcium. We shouldn't use 1.75 millimole dialysate or 3.5 milli equivalent per liter dialysate calcium. Why? Because this will lead to positive calcium balance. And the problem, as Dr. Halawa mentioned, the calcium is there, but in abnormal place. So we have bone vessel paradox. Bone vessel paradox means bone is decalcified and the vessel is calcified. Calcification of vessel is, if there is significant vessel calcification, this is very bad. And I think all treatments are marginal if it helps in this issue. So we should avoid increasing calcium for patients with on dialysis by avoiding 3.5 or 1.75 because it is available in our market.
في بعض الاسئله على الشات يا دكتور حسين لو تحب.
اوكي تحت امرك، اتفضل يا باشا.
اتفضل يا بيه، اتفضل.
مجرد سؤال بس يا جماعه، احنا معانا حد خواجات ولا كلنا عرب؟
مش عارف.
طب خلاص خلينا بقى بالعربي احسن بقى.
اوكي.
مفيش الا الدكتور طارق بس.
How to manage hyperphosphatemia in a dynamic bone disease or low PTH? طبعا very difficult point because if the patient is a dynamic, this means that the bone doesn't take calcium and phosphorus is high. So at the end of the day, we have, as Dr. Halawa mentioned, adequate dialysis. And I showed a slide about the efficacy of each dialysis modality. The longer the duration of dialysis, the better the removal of phosphorus. And we should admit that dialysis has limitation to remove phosphorus. This is why we should complement the dietary approaches, like taking history. If the patient is addicting Coca-Cola, for example, because I should educate him. The fresh prepared foods is better than canned and processed foods because, and a simple advice, all salty foods include excessive phosphate. So
actually, your slide regarding
your
slide regarding the dialysis and its effect on the calcium level is excellent. Actually, you know, you put all modalities and duration. This is very valuable slide. It will tell you the better dialysis, the more control.
The more control of phosphorus, yes. This is what, but of limited capacity. Why? Because dialysis has limitation. So we may change if the patient has which may use hemodialysis or prolong the dialysis session, and instead of 4 hours, 5 hours, or 6 hours. The dietitian rule to avoid processed food, Coca-Cola, to get rid of soup. So if we cut meat in pieces, if the patient, A patient finds the meat, cut it in pieces and boil it and get rid of soup. Yes.
Do you think it's the indication to convert patient on peritoneal dialysis to hemodialysis?
I mentioned it in one of the slides that BD, if you have, for example, phosphorus 10 or 11 milligram per deciliter and the patient in BD will not help for controlling the peritoneal because of it, phosphorus, because it is of limited capacity and efficacy for controlling phosphorus. So this is one of the indications to shift from BD to HD. Dr. Said.
Yes, sir.
You can read if you have any question, I'll respond, inshallah.
In the chat, yeah.
Female patient with stage 3 has severe أنا أفتح الشات خالص أهو. ده أسئلة كتير.
يس.
أوكي أنا تحت الأمر.
ربنا يخليك يا بيه.
ولو مش عارف أقول مش عارف أنا.
ده اليوز بتاعه في السؤال هنا is it of any value in adynamic bone disease?
Teriparatide?
Adynamic bone disease.
Teriparatide, we may use it for 1 year or 2 years for osteoporosis if we have a patient with on dialysis or CKD, and then we have osteoporosis, and the patient is hypocalcemic, so osteoporosis and the hypocalcemia, I have nothing to do. I cannot give bisphosphonate, so what I have is teriparatide. So it can help in this issue because it increases the bone formation and reduces the issue of fracture as shown from some studies.
Professor Hussein, is it available?
Teriparatide is available, yes, it's present, but it's expensive. The expenses.
It's massive expensive.
It's not massive, but it's expensive.
It's used in adynamic bone disease. The question that is here.
In adynamic bone disease, the best way is to prevent. But if it is established adynamic bone disease and the hypoparathyroid, and if the patient is exposed to parathyroidectomy, for example, I was waiting the efficacy of monoclonal antibody against sclerostin that was tested in osteoporosis with fantastic results. But there is some cardiovascular constraints on this monoclonal antibody. So up to this moment, treatment of adynamic bone disease is mainly preventive and to avoid abusing vitamin D analogs. This is why in CKD and dialysis, better to, as Dr. Halawa mentioned, to look at vitamin D level. If there is hypovitaminosis D, I give native vitamin D, and then to monitor vitamin D analog by the changes in the trend of BTH. Because if I wait at the end will be fracture, adynamic bone disease and fracture.
Last two questions, Dr. Hussein, from this, our colleagues raising his hand to conclude this session because now more than 2 hours.
في سؤال على الشات هنا. في male patient with CKD stage 3 has severe unexplained fatigue for several months. All parameters are controlled except PTH of 600. Is it related to high PTH? Then, if so, is she candidate for parathyroidectomy? This is a very nice question, and I think it is written, and I read it from the KDIGO guidelines. Even if the patient is not on dialysis, and I treat with maximal medical treatment, so I titrate the drugs, and no response, the parathyroidectomy may be done in patients, but it is less frequent. In patients without dialysis.
Excuse me, Professor Hussein.
Do you have cases, Dr. Ahmed?
Yeah, the parameters are normal in vitamin D, calcium, phosphorus, and PTH is high, 600. I think this is indication for surgery.
This is what I mentioned. The percentage of patients, because hyperparathyroidism may be associated with muscle problems, with heart problems, because as I mentioned, it is a systemic disease. with fatigue, with itching, with a lot of manifestation. How many patients you conducted for them parathyroidectomy while they, like these patients, not on dialysis and with maximum medical treatment, calcium, phosphorus are okay, but PTH is very high?
Actually, few, and you know, you'll be surprised. They were referred to me by dentists when they find, you know, abnormal cysts in the bone, and they thought, oh, let me check the PTH. PTH is high, and she was CKD3. This is actually a patient from Alexandria. So expected the PTH in this stage 3 will be normal, and all parameters, or you know, vitamin D, calcium, phosphorus should be normal. You know, so if PTH is high, it's very high. And most likely it could be a primary hyperparathyroidism in a patient with renal impairment.
I agree with this hypothesis. It may be like this. This is why in this situation, I suggest, and I want to know from your opinion about this point, to do localization. I know you are against localization, but in this case, I'll be eager to do the ultrasound of the neck and the MIBG scan or whatever the localization. Do you like localization here, or you are?
No, to be honest, you know, localization is being sorted in the primary. It's very clear in the primary. Why? It's not indicated in primary because you're looking for one gland. So, and you will find it. The problem with localization, actually, if we're going to do targeted approach or mini parathyroidectomy or unilateral parathyroidectomy. So basically, small incision targeting the enlarged gland. So you need to know where it is before you go.
Yeah.
But, you know, we don't do localized approach. We do localization. Secondary, again, you know, all glands are enlarged. So you know, localization will add nothing. And also, when you refer this patient with, you know, if it's proved to be secondary hyperparathyroidism, with one gland enlarged, actually the sensitivity of localization technique is very poor in secondary hyperparathyroidism. The surgeon will remove this gland and will leave the other 3, and you find PTH is still 600. So localization is not indicated unless redo. This is actually is not my guidelines. This is the British Society of Endocrine.
And the KDIGO guidelines the same. If the patient is symptomatic because of severe hyperparathyroidism that is resistant to the medical treatment, this is an indication, even if the patient is not on dialysis. دكتور سعيد.
حضرتك يا دكتور حسين، بالنسبه في بعض السكول زي دكتور زوكالي فروم ايطالي يقول ان لو العيان نورمو كالسيميك نورمو فوسفاتيميك وانا سيفيرلي هايبر باراثايرويدزم وانا هبتدي له السينا كالسيت او وات ايفر كالسيميمتكس، بخاف ان يحصل هايبوكالسيميا او هايبوفوسفاتيميا، ولو ابتديت فيتامين دي انالوج بخاف من الهايبر كالسيميا والهايبوفوسفاتيميا. هو بيكومباين الاثنين مع بعض زي ما بيقولوا بالبلدي، يمسك العصايه من النص بحيث ما ياخدش السايد افكت بتاع ده وده يتعادلوا. هل انت مع المدرسه دي ولا اجينست؟
As I demonstrated in the variability of medical treatment according to the countries, you can find some countries combining the vitamin D with calcimimetic to just for the, but whatever the strategy I do, I should focus on the lab parameters. And when I introduce Calcimimetics for the first time, I should more frequent in monitoring the patient until he reaches the steady state. Yes. So I may, if I decide to add calcimimetic, I'll be targeting more frequent calcium measurement until I reach a steady state for the patient. Because even I may think of increasing the dose from 30 to 60 to 90 to up to 180, and this depends upon the availability of the drug and the cost and the lab parameters. Because if there is no response and the patient has severe hypocalcemia, this I should stop.
For sure, yeah.
So if there is hypocalcemia, serum calcium 7 milligram per deciliter, on 30 milligram calcium, I made Calcimimetics, I should stop Calcimimetics in this point because hypocalcemia be fatal. No way.
Yes, sir.
But if the patient is treated with Calcimimetics and then calcium drops a little bit, and I'm afraid of hypocalcemia, this is an indication for vitamin D, because vitamin D will support calcium absorption from the gut, will balance the situation with calcimimetic. But if I have severe hypocalcemia, this is a real signal for stopping senecalcemia.
ثانك يو. انا هستاذن حضراتكم بقى، طبعا احنا تعبناك جدا وشاكرين على المحاضره.
تحت امرك يا باشا، تحت امرك.
استاذن الدكتور طارق مشكورا يمانج بقى ويشوف بالنسبه للدكتوره مي والدكتور احمد conclude the remarks of this session. ثانك يو. دكتور طارق.
دكتور طارق انميوت. دكتور طارق
انميوت بليز. حاضر.
طبعا احنا بنشكرك دكتور حسين، وبنشكر كل الساده الموجودين معانا النهارده في يوم الجمعه، يوم الاجازه، والجلسه العلميه الفروتفول دي والمفيده لينا كلنا الحمد لله. اتفضل دكتور احمد والدكتوره مي.
والله انا متشكر جدا على الدعوه الكريمه، وانا بصراحه انا بحب الميديكال اسبكت اوف باراثايرويدكتومي بالذات، لان ده جزء اللي انا ما اعرفش عنه كتير. انا اعرف امسك مشرط بس انما الميديكال اسبكت ده انا بصراحه بتعلم منكم كل ماده. ويعني ونشكر الدكتور حسين والدكتور طارق والدكتور سعيد على المحاضره القيمه دي. ودون مش حكايه يوم الاجازه، بالعكس ده احنا محتاجين حاجات زي كده في الاجازات عشان نصحصح شويه.
دكتوره مي نسمع ماسك الختام بقى.
دكتوره مي.
طبعا يعني خاص جدا عشان حضرتك كويس قوي في الميديكال نفرولوجي، فيعني حضرتك مش سيرجن بس، يعني واضح كده ان احنا سيرجن ونفرولوجيست في نفس الوقت. معلومات حضرتك طبعا ما شاء الله.
الله يسلمك.
احنا يعني بنستفيد منك جدا حقيقه دكتور احمد، فعلا يعني شكرا جزيلا.
الله يكرمك.
وطبعا شكرا للدكتور حسين ولكل الحضور، يعني very interactive session. انا كان نفسي طبعا ان يترد على كل الاسئله، لانها كلها اسئله مهمه حقيقي، يعني في اسئله جميله جدا الناس عايزه تعرف وعايزه تتعلم، في حاجات كتير بتلخبط. فطبعا دلوقتي الوقت ما يسمحش، لكن بتمنى ان يبقى في سيشن ثانيه للرد على الاسئله حتى، يعني بجد كلام مهم جدا.
انا تحت الامر دايما، وممكن ان شاء الله في قريب العاجل في شهر 9 مع وعد مع دكتور احمد والدكتور عمرو الحسيني ومع الدكتور القوسي الثلاث، ومعانا طبعا نعرض بقى الايه الديفرنت اسبيكتس بتاع السي كي دي ام بي دي، ويبقى فيها انتر اكشنز اكتر ان شاء الله. ان شاء الله. بشكركم طبعا شكرا جزيلا للدكتور سعيد والدكتور طارق على المودريشن، وطبعا كل اساتذتنا من الدول العربيه، الدكتور رياض سعيد والدكتور فيصل شاهين وكل الناس اللي موجودين من مصر، طبعا على راسهم الدكتوره مي حبيبه الكل. شكرا دكتور احمد. طبعا دكتور احمد بجانب معرفته الجميله بالميديكال اسبكت، انا بحب في دكتور احمد السيرجن لازم يبقى معاه ساينتفك باك جراوند، لان لو ما فيش ميديكال باك جراوند هيبقى ده الفرق ما بين الجراح الممارس العام والجراح الاكاديميك اللي شغال في انستتيوشن محترم. بنشكر حضرتك وسعداء بوجودك معانا، وسعداء بكل الناس اللي معانا، وان شاء الله انا هرفع الفيديو بعد دقائق، ونلقاكم دائما على خير ان شاء الله. مع الف سلامه. مع سلامه الله.